All right, welcome everyone. I think we'll make a start. So the attendance pin is 6658. Six six 5 8. Before we start, I just wanted to mention this because I've had a couple of questions. So when it comes to the assignments for the course, the names are slightly unusual. So when it comes to the poster, that's under this name. So this is the media one is the poster. And when it comes to abstract writing, that's the assignment that's labelled project, just so you make sure that you actually submit the right assignment to the right place. So this week we're going to be looking at allergy and hypersensitivity. And first of all, we're going to focus on today's lecture on hypersensitivity, and then we're going to look tomorrow at a little bit more depth of allergy. So these are the learning outcomes for today's session. So at the end of today's session, you'll be able to understand what is meant by hypersensitivity, as well as use the Jelen-Coombs category process. You'll also be able to describe each of the 4 different Jelen-Coombs categories. So this is hypersensitivity 1 through to hypersensitivity 4. You'll also be able to differentiate these different categories based on their immune mechanisms. And you'll also be able to provide examples of each, or clinical examples of each of the 4 hypersensitivities. So as I mentioned, what we're going to do today is we're going to discuss the non-IgE mediated allergic diseases. And then tomorrow we'll look deeper at the classical IgE allergies. So essentially this will be asthma and some other examples that we'll look at. So what is meant by non-IgE allergic diseases? So we've got some examples here. So the first one is drug-induced hypersensitivity reactions. So this could be a drug that's binding to the cell surface of circulating blood cells. You can also have immune complex formation. And this can occur after we've experienced a large quantity of antigen within the body. And you can also have your hypersensitivity reactions. So these are Th1 and cytotoxic T cell mediated. So this can be an example of nickel allergy. And you can also have celiac disease, which actually has features of both autoimmunity as well as allergic diseases. Now, hypersensitivity reaction really refers to the faulty or excessive immune response to antigens or allergens. And these are allergic, but they're not necessarily classical allergies. And we'll come on to that a little bit further down here. But essentially, the immune processes that occur during hypersensitivity are all normal immune functions at the site of exposure. But ultimately, they become sort of deregulated. So if you see in this diagram here, we have infection, we also have harmless environmental substances, so this will be your allergens, and as well as self-antigen, and it can all feed into hypersensitivity. So what you need to remember is that hypersensitivity is this dysregulated or exaggerated response to antigen. It can also be the failure of tolerance to self-antigen. And this is the Jelen-Coombs classification system here. So you'll see that we have 4 different types. We have type 1, which is immediate. We have type 2, which is often referred to as cytotoxic, type 3, immune complex, and type 4, the delayed hypersensitivity. Now, the type 1, which is your immediate, is the classical allergy. And this is IgE mediated, and then we have our non-IgE being type 2 to type 4. Now, it's important to remember that hypersensitivity, it is not a clinical term. It's really used to describe the immunological disease mechanisms. And the classification system of this Jelen-Coombs approach, it does have several limitations. So it doesn't take into account chronic activation, it doesn't take into account the involvement of multiple immune components, or indeed late-phase reactions. Now when it comes to classification systems, there have been several different approaches to sort of achieve this. So first of all, people try to classify by system. So you can imagine immunological diseases of the respiratory tract as an example, but really this has no relationship to the underlying mechanism. And what happens if we actually have a multi-system disease? So you can see that that's not really perfect. So people then decided to try and classify based on disease. So for example, here we've got autoimmune disease or allergic disease or a drug reaction. But really, this doesn't really have a mechanistic approach that we need. So this is where the Jelen-Coombs hypersensitivity classification came in. So this is really based on sort of like a mechanistic approach. And this is where we have these type 1 to type 4 hypersensitivity reactions. And this is a diagram showing basically a summary of the different types here and the different mechanisms. So this approach is really a mechanistic approach to actually classifying hypersensitivity. So if we look at that in more detail, I've just split the diagram into the separate parts in the corners here. But essentially type 1, which you can see over here, this is an immediate anaphylactic type of hypersensitivity, so this will be your anaphylaxis. Allergens can be pollen, food, in some cases drug allergies. So this is really your classical allergy. And it occurs very quickly, within seconds to minutes, and it's mediated by IgE. So you see we have IgE here being cross-linked cross-linking the Fc receptors in response to allergen, and we're getting mast cell degranulation. Type 2 is your cytotoxic hypersensitivity. This is in response to drugs, infectious agent, or autoimmune reactions. This is a little bit longer, taking minutes to hours, and this is mediated by IgG or IgM. And we've got this here in this diagram here. So what you can see is that essentially the antibody is binding to antigen, which is on a host cell, and the immune system is considering this as foreign, and this leads to a targeted destruction of the host cell, either by anti-dependent cell-mediated cytotoxicity or via complement systems. We then have type 3 hypersensitivity, and this is an immune complex type, and you can see that on the diagram here. So this is in response to molds that may be inhaled into the lung, also infused foreign particles such as serum sickness, as well as an aphthous reaction that we'll talk about later. This has a latency of about 3 to 12 hours. It again involves IgG or IgM. So what we've got here is we've got antibody that's binding to soluble antigen, and it's forming these circulating immune complexes between antigen and antibody. And obviously these pose a problem where they're deposited or in the tissues that they are deposited. And you can see it recruits in complement, and we kind of get this destruction really. So that's obviously a problem. And then we have type 4, which is your delayed type hypersensitivity or cellular response, and you can see that down here. This takes longer. It takes about 12 hours to a couple of days. And this is quite often seen with contact allergens. So if you have an allergy to nickel in jewelry, sometimes fragrances, or sometimes drugs, or actually toxins in plants, such as poison ivy. But what you've got here is this is involving T cells. So the T effector cells become activated by an antigen-presenting cell, and then when we see this response in the future, we get activation of macrophages and an inflammatory response within the skin. So they're the 4 different types of hypersensitivity. Now, all of the hypersensitivity reactions, they do have some common features. Obviously, they all involve features of the adaptive immune system. We all have, or they all have a sensitization phase. So you need to have had at least one prior contact with allergen, as well as adaptive immune priming. And it's important to remember that the sensitization phase can be really long-lived. It can have occurred quite a long time ago. Antigen is a protein, or it can be complex to a protein, and this is where we need to take a look at haptens. So a hapten, I've got down in the diagram here, is really a molecule that on itself, it's really too small to actually elicit an immune response. But if it can complex to a protein within the body, so this can be penicillin perhaps binding to a blood cell, or a nickel ion binding to a carrier protein within the skin. So that's a hapten, and it can then elicit an immune response on what would otherwise be an innocuous host cell protein. Type 1 to type 3, all are conferred by antibodies, so they can be transferred by serum because the antibodies all play a role in type 1 to type 3. Type 4 doesn't involve antibodies, it's cell mediated. It involves T cells, so the Th1 clones, and also a macrophage response. And then this is really just giving an overview of that table and diagram that I showed before, so just summarizing basically type 1, type 2, and type 3. Now, if we look at type 1, so this is allergy, this is your classical allergic response, so type 1 hypersensitivity, and IgE antibodies are really responsible for this type of hypersensitivity, and it's really down to an interaction between IgE and an allergen, and you can see that in the diagram here. Now, it's important to remember that healthy individuals will only make IgE in response to a parasitic infection, whereas an atopic individual, so atopic individual is someone that has a predisposition to allergies, to a sensitivity to allergens, and these individuals will produce IgE against a lot of common environmental allergens. And the way it works is the IgE antibodies actually cross-link these Fc receptors on the surface of the mast cell, and this actually causes degranulation. When we get degranulation, we get release of histamine, proteases, heparin, and chemokines, and these are all responsible for the features of an allergic reaction. Now, when it comes to type 1 hypersensitivity, we can have systemic exposure or we can have local exposure. So a systemic exposure is really where we have a large dose of antigens systemically, and this can cause a really catastrophic and systemic release of inflammatory mediators, and this is mediated by this IgE cross-linking on mast cells. And I'm sure you've all heard of anaphylactic shock, so this is where we have this vasodilation, we get airway constriction, it occurs really quickly, often within seconds. Alternatively, we can have local exposure. So if we have a local exposure to antigen, we get this localized release of inflammatory mediators. So on the skin, we can have this urticaria, which is essentially like a raised itchy rash on your skin surface. If we inhale the antigen, we can end up with asthma, or if we ingest it, we can get symptoms such as diarrhea. Now, I'm not going to focus today too much on this type 1 hypersensitivity. That's what we'll cover tomorrow. So what I want to focus on today is the type 2 to type 4 hypersensitivity reactions. So remember that these are non-IgE mediated hypersensitivity reactions. And really, they reflect the normal immune mechanisms that are being inappropriately directed against innocuous antigens or inflammatory stimuli. They can involve various immune mechanisms, so they can be immediate and delayed, but they can also be antibody as well as cell mediated. And it's important to remember again that although the actual immune mechanisms that initiate this are different, the pathology is often the same. Let's look now at type 2 hypersensitivity. So this is often referred to as cytotoxic, and it's mediated by either IgM or IgG, and it targets sort of these membrane-associated antigens. So again, we need a sensitization phase as well as effector phases, which you can see on the diagram. And the membrane-associated antigen, it can be a hapten carrier. So remember we talked about haptens binding to host cell proteins. It can be molecular mimicry, or it can be due to unknown causes. So it's often seen as a reaction to foreign substances. So this can be drug-induced. So we talked about penicillin binding to the red blood cell surface, or it can also be autoimmune. So in the sensitization phase, you can see that we've got the production of antibody in response to an allergen. And then we have our effector phases here. So this is really we're getting damage that is being driven by either IgG or IgM binding to host cell tissue. And this is causing damage three different ways. So you can see here we've got antibodies binding to cell surface protein. And we're getting antibody-dependent cell-mediated cytotoxicity. And then we're getting cellular destruction. We can also get activation of the classical complement pathway, which results in lysis, and then we get inflammation as a result of that. And then also we have cellular dysfunction. So in this case, we've actually got antibodies that are binding and blocking a normal receptor on the cell surface, and then this kind of interferes with the normal binding of a ligand. So it's actually blocking a normal receptor function. They're the three kind of mechanisms that we can see in type 2. We start to look at some clinical examples of type 2 hypersensitivity. So the first one is this immune-mediated hemolytic anemia. So as I'm sure you all know, we have the blood group system, so A, B, and O, and obviously transfusion reactions it's very important to match blood types, because a transfusion reaction is actually a type of type 2 hypersensitivity. So the blood groups are actually carbohydrates, or the antigens on the blood groups are carbohydrates, as you can see in this diagram here. And it's important to realize that actually adults will possess antibodies for the blood type that they do not have. And so that's what you can also see in the diagram here. So if an individual was to receive a transfusion of the incorrect blood type, their own antibodies will quickly attach to the donor cells, and this will trigger complement, which will then result in lysis. And it's actually the product of these degraded red blood cells that causes a problem, because they start to build up to toxic levels. And that's actually what we see in immune-mediated hemolytic anemia. And then if we transition slightly and have a look at hemolytic disease of the newborn, so this is HDNB. Now again, I'm sure you're all familiar with rhesus factor D. So this is another antigen that's found on the cell surface of the red blood cell, and it's actually a secondary classification to the ABO system. Now the majority of the population are actually rhesus positive, but if a rhesus negative mother delivers a rhesus positive baby, she can become sensitized at the time of delivery. And then after pregnancy, we get production of anti-rhesus D immunoglobulin. And then if that mother becomes pregnant again, these anti-rhesus immunoglobulin antibodies can actually cause hemolytic disease of the newborn in any subsequent pregnancies. This is actually a significant problem. Now, the treatment for this, there's a couple of options. We can perform an exchange transfusion to actually remove the maternal antibodies from the baby, but you can imagine that's quite an invasive treatment, and so we only want to do that in severe cases. But we can also try and prevent this by giving the mother anti-rhesus antibodies, and an example of this is Rogam, with the aim of actually clearing the fetal red blood cells. If we look at that in a little bit more detail, so again here we've got a first pregnancy in the top of this diagram, and then we've got a second pregnancy at the bottom. So you can see that during the second pregnancy, we're actually getting the maternal IgG antibodies that are specific to the baby's rhesus antigen crossing the placenta. And then this is mediating the destruction of the fetal red blood cells by binding to the red blood cells and then activating the complement. And again, as we saw in the previous slide, it's actually the build-up of the toxic red blood cell components that give rise to the problem. Now, following birth, this can actually be alleviated by exposing the baby to UV light, as well as these transfusion reactions. So with this phototherapy, the UV actually causes, or it enables the bilirubin to be converted into a form that can be more easily removed from the body. So that's one way of treating it, but really the best way is to actually prevent this situation in the first place by treating the mother with Rogam, and that's sort of summarized over here. So essentially this prevents B-cell activation and it prevents memory cell formation, so we kind of remove that from the equation. Now this slide is just showing some additional examples of type 2 hypersensitivity reactions. So we have this myasthenia gravis. So this is where we have autoantibodies that are directed against acetylcholine receptors on skeletal muscle. And this obviously leads to a reduction in the efficiency of neuromuscular transmission, and then this will cause sort of like progressive muscular weaknesses. We also have Graves' disease. Now this is a little bit different because here we've got autoantibodies that are actually acting as an agonist. So here they are binding the thyroid stimulating hormone receptors, and it actually mimics the natural ligand, and this will actually induce hormone, sort of thyroid hormone overproduction, and then we get this dysregulated feedback mechanism. Also multiple sclerosis. So here we have antibodies that target the myelin sheath, and that causes a whole host of problems. And then of course we've got drug allergies. So we've got penicillin, which as I mentioned before will bind to the cell surface of the red blood cell, and this will actually create a new epitope for the immune system to recognize as a foreign antigen. There are some examples of type 2. So how do we actually manage type 2 reactions? So we can have this plasmapheresis or transfusion reactions. So we can remove the patient's blood via the cell separator. We can sort of take the cellular constituents and then replace them back in, but replace the plasma with actually plasma from a donor. So the whole aim of this is to remove this pathogenic antibody, if you will, from the body. We can also look at immunosuppression. Now, this can be given alone, or it can be given in conjunction with plasmapheresis, but you can imagine that immunosuppression in itself has far-reaching consequences because you're suppressing the immune system, so it's not ideal, really. We switch over to type 3 hypersensitivity reactions. So these are our immune complex reactions. So what we have here is we have antigen-antibody complexes that are forming in circulation within the body, and then they're being deposited in susceptible tissues. So an example of this would be the Arthus reaction, which we'll talk about in a little while time. But it's important not to confuse type 2 and type 3. So quite often people do this, but really remember that type 2 is antibody binding to protein on cell surfaces, which may involve a hapten, whereas type 3 is these antigen-antibody immune complexes. Okay, so it's important to kind of separate the two out in your own mind. In terms of immune complex formation, this is actually a natural phenomenon of antibody being complex to antigen, but normally these are soluble and would be quite easily removed by the spleen and liver, but they can overwhelm the sort of systems that would normally clear this, and then this can cause us damage. So what can happen is we can get precipitation and deposition in tissues when these systems become overwhelmed, and this will lead to complement activation as well as inflammatory cell recruitment. It may also trigger the release of inflammatory mediators as well as vasodilation. So you can see that we're basically getting this sort of inflammation in the tissues, and this is going to cause a lot of damage. But of course, remember that we can get proteases being released, and this can then damage connective tissues. And then we can also get clot formation. So really, it's kind of this cascade of events occurring. Now, type 3 hypersensitivity reactions really do affect the blood vessels as well as the kidney. So you can see here that we're getting inflammation in the small vessels, we're getting activation of complement, we're then getting recruitment of neutrophils and macrophages. So it's leading to this inflammatory situation. And then you can see that also we're getting build-up within the kidney, so this is causing problems here. So essentially, for a type 3 reaction, we have 3 steps. We have this immune complex formation with the antibody binding to the antigen. We're then getting this immune complex deposition somewhere in the blood vessels or within the kidney. And then we're getting an inflammatory action. So we're getting activation of the classical complement system. We're also getting activation and recruitment of macrophages and neutrophils, and everything being recruited to this tissue and then causing damage localized to where these immune complexes are being deposited. So if we start to look at the cause of this, now the antigens that induce these complexes, they can be endogenous or they can be exogenous. So this can be as a result of infection or drugs that perhaps an individual is taking. But they occur in a case where the antigen can't easily be removed. So an example of this would be autoimmunity. So immune complex deposition really is quite a prominent feature of several autoimmune diseases. So we start to have a look at some clinical examples of type 3. So immune complexes can form systemically and then circulate around the body, but they can also remain localized. So when they're systemically, you might see serum sickness, or if it remains more localized, you may well end up with an Arthus reaction. But essentially, we have autoimmune diseases, so we have systemic lupus, we have rheumatoid arthritis, because you can imagine if those immune complexes get deposited in your joints, that's going to cause a significant problem. We also have drug reactions, so we have allergies to penicillin, for example, and then we have some infectious diseases, so meningitis, hepatitis, as well as malaria. But when it comes to the symptoms, we have fever, rashes, lymph node enlargement, joint pain. We also get vasculitis if that's occurring in the blood vessels. And then, as I mentioned before, if it's occurring in the joints, you'll get arthritis. Now, the Arthur's reaction is basically a localized type 3 hypersensitivity reaction. So this diagram here is really just showing sort of immune complex formation. So if we have an excess of antibody or an excess of antigen, it's really kind of that equivalence between the two where we start to see this immune complex formation, as you can see in this diagram here. So what is an Arthur's reaction? Well, it's a localized acute type 3 hypersensitivity reaction, and it's quite commonly seen after vaccination. So for instance, a booster vaccination or in response to an insect bite. And what you're getting is a localized inflammation of the small blood vessels near that injection site or the insect bite. And it's an inflammatory reaction, and it's caused by the injection of the antigen in an individual that already has a high level of circulating antibodies that are specific to that antigen. So what you end up with is swelling and a localized bleeding at the injection site. And it tends to be about 4 to 10 hours after the injection if you were giving like a booster vaccine. This is an example of actually what it looks like. So this is an Arthur's reaction. So you can see it's this kind of localized reaction. You've got this vasculitis going on, and this is occurring as a response to complement activation. So this can be in response to, as we talked about, a vaccination or an insect bite. But the individual needs to already have, essentially, a high antibody titer against that antigen that they're seeing. Now, we can also get Arthur's reactions in the lungs. And this is known as extrinsic allergic alveolitis, or EAA. It's a bit of a mouthful. But essentially, a patient will become sensitized to an environmental antigen by repeated exposure. And they start to produce large quantities of IgG. And as they continue to get this re-exposure to the antigen, they start to form immune complexes where the antigen is binding to the antibody. And this is quite commonly seen with mold spores, and this is known as farmer's lung. So farmers can be quite susceptible to this because of the mold spores that are present in hay and within the farming environment, but also seen in response to pigeon feathers and also pigeon stool. And this is seen in people that keep pigeons, so pigeon fanciers. It's known as pigeon fancier's lung. So initially this is kind of transient, but with repeated exposure you start to get scarring of the lung, and you can actually see that in this X-ray here, where we've got scarring sort of in the lower portions of the lung. So it starts to cause a problem over time. When it comes to diagnosing and treating type 3 hypersensitivities, immune complexes in the blood are actually quite fragile, and it's difficult to quantify because of this. We can detect, however, immune complexes in the tissues, but this is obviously requiring a biopsy, which may not always be an option. Now, what we can do is we can look for the relevant antibodies. We can also measure the amount of complement activation, because if you think about a systemic reaction, the complement factors will actually be sort of depleted in the body because they're being used up because of that immune reaction. But we can't use complement factors to diagnose a localized type 3 reaction, only for the systemic condition. But really, the main therapy for treating a type 3 hypersensitivity is avoidance. So you want to avoid that allergen wherever possible. You also want to think about perhaps decreasing inflammation, so you can think about using corticosteroids here, but also decreasing antibody production, and this is feeding back into immunosuppression. But obviously, immunosuppression is not necessarily a route that you may want to go down, because again, it has far-reaching consequences. And then this moves us on to type 4 hypersensitivity. So this is our delayed hypersensitivity reaction. Now, remember that unlike type 1 through to 3, which are humoral or they're antibody-based, this is actually a cell-mediated response. So it's initiated by T cells. And again, it requires a sensitization phase as well as an effector phase, but it requires a delay for the reaction to develop. And it's characterized by a recruitment of macrophages and inflammation at the site where we encountered antigen. Now this slide is just summarizing the sensitization and effector phases. So you can see over here we've got sensitization to an allergen. So we're getting exposure to an allergen, we're getting an initial T-cell response that's being triggered, and this is a CD4-TH1 subset. We're getting expansion of our T-cells. And then we have this effector phase. So once we get a second exposure to the antigen to which we've been sensitized against, we get production of these TH1 inflammatory cytokines. And this results in macrophage activation and recruitment. So you can see that this is the process that's occurring. And this takes obviously a little bit longer, which is why type 4 hypersensitivity reactions are often called or referred to as being delayed. If we start to look at a couple of clinical examples, so if we switch our attention towards tuberculosis and also the tuberculin test, so a type 4 hypersensitivity really does play a major role in the tissue damage that we see upon infections with intracellular organisms that are quite slow growing. So tuberculosis is an example of this. So really we've got this prolonged inability to clear antigen, and this results in granuloma formation, which is something we talked about a couple of weeks ago. But we can actually make use of this clinically. So the MAN2 test, or which is actually another name for the tuberculin test, is actually a diagnostic procedure that's taking advantage of this type 4 hypersensitivity. So what happens here is that tuberculin is injected intradermally, and this causes this local inflammatory response that can occur over 24 to 72 hours. And this is a good way of determining whether an individual has been previously exposed to tuberculosis. And so this is just going into that in a little bit more detail. So what happens is the antigen is actually injected into the skin, and then it's allowed to progress for 72 hours. Now, if that individual has been exposed to antigen before, we start to get a TH1 response. We start to get inflammation, and basically, we're getting recruitment of phagocytes and release of inflammatory mediators to the site. And this indicates that this particular individual, if they get swelling, if they get a reaction, it indicates that that individual has a population of TH1 cells that have been previously sensitized against the antigen. Now, this used to be, it says here it's commonly used in the United States to test for tuberculosis exposure, but certainly when I was growing up, it used to be used here. You'd be given this MAN2 test, and then a few days later, you'd go back and they would check, and if you'd had a reaction, you wouldn't need the TB vaccination. If you didn't have any reaction to the MAN2 test, then you would get the TB vaccination. But I think vaccination strategies change, and I believe I'm right in saying that they don't routinely vaccinate people against TB so obviously, probably about 10 years ago, it was commonplace that everyone would get the TB vaccination if they hadn't had exposure to TB before, as determined by the MAN2 test. That's just an example of how you can use a type 4 hypersensitivity in a clinical situation. And then we have contact dermatitis. So I'm sure that some of you have come across this before. So essentially, we have these sensitizing agents. So these are typically highly reactive small molecules that are really easily able to penetrate the skin. And so an example of this would be a nickel allergy or poison ivy. And they react with self-antigens. So again, you get this protein-hapten complex. So the nickel is a hapten which will bind to proteins in the skin and then form this complex which can be identified by the immune system as foreign. These are picked up by dendritic cells in the skin, and then you're getting presentation to T cells. Now these activated T cells will then migrate into the dermis, and we'll get this inflammatory cytokine being produced, and we'll get itching and swelling, and you start to get this blister formation. This is commonly seen with cosmetics, pharmaceuticals, so metal ions, for example, nickel, which is what you can see here, and then poison ivy, which is giving this reaction here. So there's really nasty blisters that form on your skin. This all occurs like a few days after exposure to. So we start to look at some examples. So we have, as we talked about, intracellular bacteria like TB. We also have intracellular fungi, and then parasites. We have some viruses as well. But also contact antigens such as hair dyes, nickel salts, and then poison ivy, as we just mentioned. So how do we manage this? Well, in an ideal world, you want to avoid the allergen wherever possible. So if you know that you've got an allergy to nickel, then you really want to avoid that. Again, we can look at immunosuppression, so blocking this T cell activation, and also the possible use of corticosteroids to sort of blunt down the immune system. But really you want to avoid that. It's also kind of interesting because if you look at nickel, quite a few people will have a nickel allergy on the skin, but if you look at people that may well have braces on their teeth, braces actually contain nickel because they need to be pliable. But an individual with a nickel allergy can quite often have braces on their teeth which contain nickel and not have an allergy response. And that goes back to tolerance and oral tolerance and that kind of thing, and just having a different sort of immune system environment in the mucosa that is different to the body. And that's actually really quite interesting. So this is summarizing the type 1 to type 4 hypersensitivities. So we've kind of run through them all today, but what we'll do is we'll focus tomorrow in a little bit more depth on type 1 with a focus on asthma. So if we just look at the pros and cons of the Jelen-Coombs classification system. So the pros are, it's really the only successful attempt to classify the disease by the mechanistic approaches. It provides a useful framework to be able to describe and understand the various diseases. But as I mentioned before, it's not really useful clinically. It tends to be a bit of an oversimplification because you've got to remember that also we've got many components of the immune system being involved. It's not just necessarily as clear-cut as the classification system would suggest. And then, of course, we also have many diseases, particularly in the chronic phase, which will be utilizing multiple components of the immune system. And therefore, they don't necessarily fit quite nicely into this classification system. I've got a little quiz now, if you want to jump on Poll Everywhere, and just have a couple of minutes doing that. And the code is on the screen as well. Right, it looks like most of you have got there, so I'll just give you a few seconds more. Okay, so let's start to run through this. So the first one, once sensitized, free antigens cross-link the antibodies expressed on mast cells or basophils, which cause the release of immune mediators. Is this type 1, type 2, type 3, or type 4? It is, of course, type 1, and this is what we'll talk about in more detail tomorrow. The effector cells are activated by an antigen-presenting cell. When the antigen is presented again in the future, the memory T cells will activate macrophages and cause an inflammatory response. This is, of course, type 4, which the majority of you got. The next question, antibody binds to soluble antigen, forming a circulating immune complex. Elimination of circulating infectious agents by immune complexing and elimination by phagocytosis. Is this type 1, type 2, type 3, or type 4? It is, of course, type 3, so this is your immune complex formation. And then the last question, or not, I don't think it's the last question, but antibody binds to antigen on the target cell, which is actually a host cell that the immune system considers as foreign, and this leads to cellular destruction via complement. This is, of course, type 2. And then a college student develops a blistering rash on his legs a day after returning from a camping trip. He visits the health clinic and a nurse makes the diagnosis of poison ivy reaction. Which of the following statements is correct? So it's the second one. So his rash is caused by activation of CD4 and CD8 positive T cells that are specific for peptides of this uracil modified self-protein. So this is actually a hapten that's in poison ivy. And then we're getting sort of inflammatory cytokines and T cells. So if I go back to presentation. So we have here this situation. So this is this poor chap called Paul. So what he's done is he's come into contact with poison ivy, but he's got these lesions on his skin, but he's also got not just lesions on exposed skin, but areas of skin that were covered, like his trunk and in his groin area. So how do you explain that? Why is he getting a rash in places that didn't come, underneath his clothes? Any ideas? Anyone? Yeah. Yeah, it's kind of just spreading it around, really. The second one, how would you explain the recurrence of lesions after discontinuing corticosteroids? So he's been given corticosteroids, inflammation's gone away, he's come off them, and suddenly the blisters have come back. So anyone think how that might happen? Yeah? Yeah, but why would the immune system still be reacting to it? Let's going back to thinking about the hapten. So uracil, which is this component poison ivy, it's a hapten, so it will bind quite tightly to skin cells, and obviously that's still there in the body. So you might have dampened down, like you said, the immune system, but that hapten protein complex is still in the body and is still therefore sort of able to be recognized by the immune system. So it says here, Paul obviously must take great care to avoid poison ivy for the rest of his life because subsequent reactions may be more severe. Why would that be? Why would Paul possibly have a second exposure that's even worse? What's a good feature of the immune system? Memory? Yeah, so it's the memory response. So obviously he's going to really need to be very careful to avoid it. Now, how would you confirm that the contact dermatitis that Paul experienced was caused by poison ivy rather than by another chemical such as one found in the trees of poison sumac, or another plant that can cause contact dermatitis. So how would you actually test that? Yep. Sure? Anyone else? We don't really want to subject Paul to a whole variety of tests giving him blistering reactions. So how what? Yeah? You could do, but I mean that's unless we start exposing him to other things, right? So is there a way that we could perhaps take a sample from him and test? Think back to week 3 when we went through the immunologist toolbox. You remember the MHC tetramers? So we could do that to measure his T cells to check whether they're specific for antigen for the poison ivy. That's one way you would test that. Okay, that's great. And then if you want to check up on any reading, you can find that in Janeway or Kubi. And then tomorrow we'll go through more classical allergy and asthma. So I'll see you guys tomorrow.